Good evening, ladies and gentlemen. I'm sitting here in Vienna, and it's a pleasure for me to talk to you about treatment-based classification for hand surgery. So I will share my screen. Does it work?
That looks good, yes, great.
Looks good. Okay, so what are the prerequisites to treat radius fracture? I have to do some biomechanical and radiological considerations to find the right treatment. I will show you a treatment-based classification. My disclosure, I'm consultant in the Medartis company. The background is there is a vast range of specially designed plates and screws to provide ideal stabilization for specific fracture types. You can see from left to right. The challenge for the clinician is matching these implants to specific fracture types in order to provide optimal treatment. You can see a lot of different plates on different fractures. What do we need? We need a classification, and all of you know the AO classification that is based on plain X-ray, but it is only a descriptive classification and shows you nothing how to do these fractures, how you operate these fractures. Much more interesting is this classification from Bechlaner. It's based on pathomechanics, and here you can get a lot of more important information about the type of fracture. My classification is based on that CT-based classification from Brink and Wrigley. They proposed a four-corner concept where the critical fragment that causes the shift of the corpus in different direction is called a key fragment. You see here, it's a very simple classification: the radial corner, the dorsal corner, the vola, and the ulnar corner. The question is how to classify a fracture. What do we need? What do we see based on plain X-ray? It's clear that we all need a plain X-ray, because here we can see the dislocation of the articular fragment in relation to the shaft. You get a global overview over the fracture. And it's mandatory today, if you have an intra-articular fracture, that you do a CT scan. And here you can see an axial view shows best the sigmoid notch, which is not well seen in the normal plain X-ray. The AP and side view of the CT scan completes your three-dimensional understanding of the fracture in your brain, so to say. I don't like 3D reconstruction, but sometimes it's not so bad for better visualization at one glance and to show it to your patient. But you should do your 3D image in your brain with the normal slices. Today we have even 3D prints, maybe for planing, which you buy fits better to the bone. It's a helpful thing. And yes, it will be maybe also important for the future. We wanted to know where are the fracture lines. Are these fracture lines, as you can see it here and in the axial CT scan, in a distinct fashion, or are they just a randomized pattern somehow without rules? And there we found a really interesting paper from Greg Penn. Ligamentous origins are preserved in distal radius intra-articular two-part fracture and computer tomograph-based study. You see that the fracture lines are going between the ligamentous insertions, they so to say reinforce the bone, and they are and they form with the bone osteoligamentous unit. I will tell you later on. Now, some biomechanical considerations in stability. There is a tendency, as you know, of the carpus to glide ulnarly and volarly along the ulnar and volar inclination of the radius. And against this tendency works on the dorsal side the so-called dorsal V ligament, and on the volar side the two volar ligaments, the proximal and distal volar ligament, hold the carpus in position. And together, the dorsal and volar ligaments form a sling which hold the carpus in position. So, depending on the direction of acting forces, we get radial-sided fracture or ulnar-sided fracture. And then it depends if the forces act more on the dorsal side or more on the volar side. You get dorsal fracture or volar fracture. All these two fractures are possible with a dorsal extended wrist, not as we mentioned previously that you have to flex your wrist to get a volar fracture. Even when the carpus is hit from the lunate in an axial, with an axial force, you get a central depression of the articular surface. In partial intra-articular fractures, 6 different patterns can be described. At least one corner remains always intact and in continuity with the shaft. The red part here is displaced in relation to the shaft. We call these fragments key fragments because they are the key corner for the stability of the carpal bones which attach to them. And here you can see these key fragments. The key fragment dislocates with the lunate to different direction. You can see here to the volar side, maybe with a small rim fragment, to the dorsal side with a dorsal rim fragment, with a bigger dorsal fragment to the dorsal side, or even to the radial side with a radial side, it's a key fragment. All common is that these key fragments are the origin of important ligaments. You can see here on the bones, the origins of the ligaments. And these osteoligamentous units represent key type fractures. So I will go through the different key types. The first one is a radial key type, and you see here the radial styloid is coupled with the radioscaphoid radiolunate ligament as an osteoligamentous unit and displaced the whole carpus to the radial volar or radial dorsal side. Sometimes the fracture line goes through the SL space, and also the ligament ruptures. And you can also use the ligaments to reduce the carpus as an osteoligamentous traction unit. The volar key type fragments can be big fragments or small fragments. As you can see here on the X-ray, here a bigger one and here a smaller one. The smaller the fragment is, the more it is overlooked and underestimated. We will see some cases then in the future. The volar key corner is a corner where the osteoligamentous unit is from the ulnar ligament and the UCL, the ulno-lunate and the ulno-triquetral ligament. They hold the carpus in the position, and when this fragment goes to the volar side, the whole carpus dislocates here, 3D reconstruction. The whole carpus dislocates to the volar side. You can see here a drawing where you see the volar V ligament, which hold the carpus normally in position. They act like a pellidi here and support the whole carpus from volar dislocation. Here you see a volar radio-ulnar type where the whole volar margin is fractured, you can see here the green star. The dorsal aspect is still in contact with the shaft. When you fix this fragment, you get stability of the whole corpus. Here you see different types of Vola fragments. Here you see a small Vola fragments, a shear fragments, which if you have Vola directed forces, you get such Vola small fragments. If you have a dorsal dislocation of the corpus, you get also a Vola fragment, but it's a tear out fragment and not a shear fragment. And during the reposition, which you will see in the next slide, it's turned around 90 degrees. These small parts, small Vola key fragments can only be on the ulnar side, on the troublesome sigmoid notch, or the whole Vola margin. And then you see you have a rotatory dislocation with ulnar fragment, or a symmetrical Vola dislocation with the whole Vola margin. Here you can see the mechanism of the turning around of the Vola fragment from 90 degrees. During the dislocation, the tear out fragment is torn, and then after the reposition, it's torn 90 degrees in the other direction. And these fragments are indicators of the displacement that has taken place at the direction of the dislocation. The next type is a dorsal key type. You see here the whole corpus dislocates with the dorsal fragment on the dorsal V ligaments to the dorsal side, and the volar ligaments are ruptured. You can see it here on the axial CT scan and on the dorsal, on the side view of the CT scan. Here we have two pictures. Both seems to be a dorsal dislocation of the corpus, but anyway, that's a real dorsal key fragment because the corpus is dislocated with the key fragment to the dorsal side. Here, the corpus is still adapted to the with the volar ligaments to the volar key fragment, and we have here a volar key fragment with a dorsal dislocated corpus, and the treatment is quite another one because here you have to stabilize at first that one, and here the dorsal V ligament. A central key type, that means you have a central force which dislocates the corpus into the metaphyseal area, and you can see here the CT scan shows the whole, the impacted fragment during the normal X-ray shows not a lot from that really severe fracture. In the side view, you have now the three key types, central impaction, a volar, and the dorsal key corner. There are not only key type fractures, but we have also so-called non-key types, such as a three-part fracture. Well, we could see, the question is, it is really a non-key type. It is a three key type fracture because we have three key fragments. If you get these three fragments stable, you have a stable corpus. You see here the plane X-ray, the axial CT scan with a three-part fracture, and here's a 3D reconstruction. Very ugly fractures are these distal shear fractures because you have here somehow key fragments where the ligamentous insertion is still alive, but in the middle of the fracture, you have also fragments which has no ligamentous insertion. They are very wide distal located fracture, and it's very hard to reduce them and to catch them. And then the comminuted fractures, you know them all, consists of many small fracture elements which can hardly be grasped or stabilized. In these cases, there is no addressable osteoligamentous unit. They are like swimming eyes, and you have to decide if you go in and make some attempt to fix them, or if you put some other device on it and let them how they are. So we have a lot of key types, fractures, radial styloid, sigmoid notch vola, volar rim, dorso-ulnar, central key fragment. It is important to identify these key fragments, to have a concept and to go for it. So now, what are our goals for a fracture-specific treatment? We want a plate which can be the jack of all trades. But the question is one plate for all key fragments possible? Can you stabilize all this fracture with only one plate? So how come we to do a solution? What plate will catch best the fragment? We have the global information with our plain X-ray. We get special information over the CT scan and maybe over the 3D scan and some models for teaching and planning, and then use a treatment-oriented classification for find the right access and strategy to prevent dislocation. Define a plate which catches the fragment best. So one case here, you see a 20-year-old male who has a fracture here on the dorsal side, and it is clear it is a dorsal key fragment. And the surgeon opened it from the volar side. And that's the question, if that makes sense, because he wanted to reduce the fragment well with some maneuvers from the dorsal side. And he wanted, because he always wants to go in from the volar side in 90% of all cases. And he tried to fix this fragment from the dorsal side, and look here, it looks not so good. And the next day I said, well, I want to see a CT scan, and here you can see he did not fix his fragment in the correct position, and then he had to go in with an accessory access on the dorsal side, put out the screws on the volar side and fix it, and on the end it looks quite fine. So it is important to identify the key corner. Here we have that dorsal key fragment, and then you have to go in. Maybe the best one is that you go in on the dorsal side and fix the dorsal key fragment from the dorsal side. But there are other people who say, okay, when I know that I have a dorsal key fragment, and when I know exact the position of this fragment, I can do also an indirect reduction. And when your screws are in the right position, you can even do a dorsal key type from the volar side. You have just to know that your screws must be inside the dorsal fragment. Here we have a volar fragment, identify the key type, a volar key type fracture, and you see the surgeon chose a volar plate, and he did a fracture-specific fixation of that fragment. Here we have a volar key type with a small rim key type, and a plate for that key type will not work because the plate ends here, and the ligamentous unit is from that volar rim to the carpus. You see already here the dislocation to the volar side, also on the CT scan. And here it's clear you go in from the volar side and fix it with some devices. Here with a hook plate or a bank of hook plates. And then you have always to prove the stability of your carpus. If you have, even when you fixed your volar fragments with the bank, if you have still a dislocation, a tendency of dislocation to the volar side, we put in transfixing K-wires to the lunate for 6 weeks and remove it after the cast removal. That gives us a more stable situation. Sometimes if the rim fracture goes Also on the radial side, we put also in 2 key wires because we have then a symmetrical dislocation to the Vola side. Then we need here a K wire and here a K wire. Here you can see a combination of types and plates. You can see a rim fragment, a metaphyseal rim, a metaphyseal volar ulnar fragment, and a styloid fragment. So you have to decide what you do first. At first you stabilize your rim fragment, and then you can fix the other important keys here, such as with this plate. It is a FPL plate, a plate with incision for the flexopolitis longus. Here the so-called song concept is not working because you can put that plate very wide distally and the flexopolitis longus is in the cutout and has no contact to the plate. And this plate you can also use in combination with these hook plates. And have a look here on the different shape of plates. That's an adaptive plate, the so-called watershed plate. That's the FPL plate, which reaches a little bit more distally on the radial side and catches also better the radial fragments. That is a so-called ulnar rim plate from our friend Kawasaki in Tokyo invented. And here a hook. So you have to decide if you have 1, 2, 3, 4, which type of plate you use to fix these plates. And it is important that you know that, because on your set, on your hospital mostly are not all the plates. You have to tell your nurse what you want to operate on the next day, and that she should prepare the set maybe with that special plate, or you have to ask her if the hook is on the set, and so on. You have to check your fracture previously that you have the right material. And in the future, it's also very important because you get single-use sets and there maybe is only one plate and that must be the right plate. So you see here the treatment option for all these Vola key type fractures, and they are all treated with different plates or with different hook plates. Here even cannulated screw are useful, especially if you do an arthroscopic reduction of the articular surface. You can very well use these screws. Here again, the different possibilities. Here the hook plates, the bank, and here the fracture plate for the ulnar rim fragment, and here a special plate which has screws, self-tapping screws who can fix also small fragments. Here you can see also the transfixation of the carpus, the intermediary transfixation, because he could not reach the whole stability. Because even when you fix a Vola fragment, you can have an accessory ligamentous lesion, and that you cannot handle with plates. A Vola radial ulnar key type, you see here the dorsal aspect is intact and stays in contact with the shaft. So you have only to stabilize the Vola fragments, and this surgeon did here a fracture-specific treatment. It's clear that you could here also use a frame plate instead of these two plates. There are always more than one solution for one fracture type. The radial key type, you see here the radial styloid here is impacted and dislocated to the radial side. And here we use mostly radial oriented plates. That means they are radial longer than on the ulnar side, so that you can catch, especially when these fragments are comminuted, then you have with this type of plate more possibilities to support that radial key type. But if it is a single fragment, you can also use this cannular screw, and maybe with arthroscopic assisted reduction, you can do it with a really very small incision if you know that it is a radial key type. So you can see here the different plates that are two watershed plates. They stay under the watershed line. The FPL plate, the adaptive plate, and that's a radial oriented plate. And this plate always goes over the watershed line on the ulnar, on the radial side. And here you have mostly the contact point with the flexor pollicis longus. And in a few cases, you have also to remove this plate if you have a zone 2 situation. Three-part fracture, we were talking about it previously. It is per definition a non-key type fracture, but I can say it is a three key type fracture. That means if you can fix with one plate, if you can stabilize all these three parts of this three-part fracture, you get a stable situation. And look here, it's always important from the first row, you stabilize the Vola fragment, and from the second row, the dorsal fragments, because they go up to the dorsal margin of the radius, and you have to take care that you don't choose them too long. Shear type, one of the very ugly fractures. We have already said that there we have some fragments which have no junction to the ligamentous stabilizations, like this central fragment. You have to use plates. It's difficult to reduce them. They are sometimes really like swimming ice, and you have to go very wide distally, like with this frame plate, or do also a fracture specific screws inside with arthroscopic support. Or as you can see here also, when it is dislocated to the dorsal side, from the dorsal side with a frame plate and an accessory stabilization with two transfixing K-wires through the carpus. What's that? As you can see here, that's a central impaction, a central key type, and there are some different solutions. You can go also in from the Vola side, drill a hole, and then reduce the impacted fragment indirectly, and then support it with some K-wires, and then put a lot of screws from two rows under the impacted and reduced, previously impacted and then reduced fragment to stabilize it. That has just to sit on the screws, and then it is stabilized. Also, arthroscopic assistance is here a very good reason. A central key type, if you cannot reduce it percutaneously, then it's sometimes better to go in from dorsally, because you have here a good insight of the articular, direct view of the articular surface, but you have to take care not to devascularize these hull fragments with your access, and then get a beautiful X-ray and further on, but necrosis of the fragments. A central key type is a Vola and dorsal corner. That means, yeah, that's not only a central key type, it's also a really comminuted zone on the dorsal and Vola side. If you have identifiable fragments where you think you can fix them, where you can put in some screws, then you can go in at first from the Vola side and then accessory from the dorsal side, and make a sandwich with dorsal and Vola plates. Then we are here on the most ugly fractures, severe comminuted fractures. I said, if you have addressable fragments, you can go in from both sides and try to fix them, but don't overestimate your power. Sometimes it's better not to go in and put in maybe a spanning plate for temporary spanning this fracture, and maybe go in secondary or wait for healing for a secondary salvage procedure. Because the worst thing is if you go in from both sides and you cannot fix these fragments and they are swimming around and you end up with an external fixator or something else. So as a conclusion, it's important that you recognize the fracture pattern, that you classify it. It's important that you have a CT scan. Identify the key corner and go for it. Use different types of plates for special type of fractures. Keep in mind the fixation of specific fragments. Open mind to double approach, but only when you need it. Percutaneous or arthroscopical assisted reduction prevents, as I said, devascularizing the radius, and you should maybe prefer it before you open it up from both sides. Hopefully, I can offer you this web-based classification for your iPhone or your other handy, and it's in a beta version already existing and works very fine, but it's not on the market. It will be on the IBRA website within the next month. So at last, I can show you a case. It was a case which gave me a course participant. As you know, we are giving a lot of courses. There were 8,000 participants in our Wiener Hand course already the last 40 years. And one of these participants which did our wrist course gave me that case. And as you can see here, it is not a really funny case because it's one of that fracture types which are already described. It is a non-key type fracture, a shearing fracture, where you have fragments which are not in conjunction with ligaments. Some are some are key fragments, dorsal or vola, but other ones are dropped out of the articular surface. And as you can see here, this participant had a plan how to fix this fracture. He produced here this sheet and he colored the fracture in this way. You see here on the dorsal side, you have here one big radial fragment. On the volar side, you have a volar key corner fragment. And you can see here on the side view that one of the articular surface fragment is turned out and 90 degrees turned and dislocated to the volar side. Here you can see that very clearly on the CT, on the 3D reconstruction, and also here blue on the volar side view, on the side view. Yeah. Here you can see the 3D reconstruction running around. The patient had at first an external fixator. Sometimes it's helpful if you have not the right stuff for operating it, for waiting maybe 2-3 days, and then with the right equipment going at this fracture. And as you can see here, he had a plan how to do it. At first, he wanted to reduce the radial styloid. You have to decide if you want to do at first the ulnar corner or the radial styloid. He did at first the radial styloid. The second step was he put it the turned out articular fragment, you see with this K-wire, with a joystick into the articular surface and hold it in position, and then reduced with a clamp the ulnar-sided ulnar vola key corner. Then he saw that the radial styloid was not quite good reduced because he had some slight rotation failure, because you must know the articular surface has no contact to the shaft, and you have to look how is the right rotation from the shaft to the articular fragment. He did again the K-wire out and did a re-reposition of the radial styloid intermediary. Then he put on this ulnar Kawasaki plate on the Vola side. Then he after reduction of the radial styloid, he put it in a double-headed screw, and then on the Vola fragment, which is here blue, he put in a hook plate with 2 holes with these self-cutting screws. And you can see here, he got a really nice articular surface, a centered carpus. That's the most important thing, more than a very good articular surface, that the carpus is centered. The palmar inclination is reduced, and he has a stepless articular surface. You see here the dorsal entrance, here you see the proximal row, and here the dorsal fragments, and here on the Vola side, the Vola fragments, which are held with this hook plate and this Kawasaki ulnar-sided wrist plate. And that's what he got, a really amazing result, and also radiologically a really good restored articular surface in both views. Okay, that's the end of my presentation. I hope I could give you some advices how to treat radius fractures.